Hello and welcome to today's Preventive Medicine Grand Rounds for November 1st, 2023. My name is Michael Cherry. I'm with the CDC in the Division of Workforce Development. I'm the Residency Program Director for CDC's Preventive Medicine Residency Program and Fellowship. There'll be continuing education credits will be available for today's Preventive Medicine Grand Rounds. The information will go out through the consolidated daily announcements and available through the CDC's training and continuing education online website. Our topic today for today's CDC Preventive Medicine Grand Rounds is challenges with death data, why they matter to the public health practitioner. And it's presented by an alumnus of our program, Dr. Anindita Issa, who's will be presenting today. So Dr. Issa, I'm going to turn it over to you.
All right, thank you so much. Good afternoon, and thank you all for attending this talk on a topic that means a great deal to me. So many years ago, I'll give you some background. I was a fellow in forensic pathology, and I had an attending medical examiner, and he was really passionate about bridging mortality data and public health. So he didn't just teach me about performing autopsies, he helped really open my eyes to the crucial role that mortality data has in improving public health outcomes. And this is what inspired me to join public health as an EAS officer, where I worked on disaster-related mortality projects in the National Center for Environmental Health. I lead with this because some of the examples I use will be about disaster-related deaths. After EIS, I completed Preventive Medicine Fellowship at CDC, where I learned skills in program evaluation and project management, among others. So you'll see that this presentation kind of melds these professional experiences of mine, but also gives you a context of why death data is important to public health and highlights the recent initiatives to improve it. So in this presentation, I'll go over the following sections, but not necessarily in the order shown here. Imagine this more of a storytelling where I'll highlight salient points and themes throughout. I'll give you an overview of how mortality data is collected and reported in the US, where I'll go over history of medical legal death investigation and mortality data flow. Many different organizations have made great strides in addressing these challenges, especially over the past several years, and there is still room for furthering these efforts. So we'll go over the initiatives and next steps. And finally, what does this mean to you as a public health practitioner or those who have trained in preventive medicine? Although we'll talk about significance throughout, we'll summarize it at the end of the presentation as well. So as we go through this presentation, you'll notice these challenges in mortality surveillance as recurring themes. There is the theme of regulation and governance, which is tied to heterogeneity and the complexity of the systems. There are challenges with training of professionals involved, as well as shortages of funds and personnel. And finally, there are needs for interoperability between data systems and collaboration between different organizations. You'll find that these challenges are not unique to death investigation data, as you may be familiar with the same themes in other surveillance systems and programs. So now that you understand a bit about this presentation's framework, let's dive into the story. So why does death data matter to public health? Along with morbidity data, mortality data contributes to the narrative on the health of a community or a state or territory, or even the country as a whole. Mortality data tells a story about the most severe consequence, and it may give a sense of urgency to translate that data into action. You're probably familiar with the epidemiologist bathtub analogy, where incidence is the water coming in through the faucet and prevalence is the water in the tub. And mortality is the water down the drain, and the water that evaporates are those who recover. Well, in this analogy, when the tub water is low, it could be a good thing, more people are recovering, or it could be a really bad thing, more people are dying. When that pool of water down the drain gets bigger and bigger, we have an urgency to act in a timely manner to prevent more water from draining. So mortality data provides that data for action. The end users of death data, which include you, the epidemiologists and other researchers, who can translate that data into action. They can do this by monitoring threats, they can recognize trends, they can allocate resources, establish prevention programs, measure the effectiveness of strategies and response efforts, and even influence policy change. So medical examiners and coroners are among the initial groups to identify preventable causes of death, and thereby they played a key role in protecting the public's health. For example, one of the most famous examples is a law that was enacted to require the use of infant car seats. And that all began because an autopsy technician noticed higher death rates in infants compared to older children. In recent decades, mortality data from death certificates have been used to track spikes in death related to drug overdose. When talking about these challenges, I mentioned that there's not enough oversight of different death investigation systems at the national level. That oversight is needed because there is such a patchwork of different medical legal death investigation systems. Not all deaths are referred to the investigation offices, but those of non-natural homicides, suicides, accidents, or undetermined manner are typically referred. The way these offices are set up vary from state to state, where some states have each county with a coroner's office or a medical examiner's office, while other states might have a centralized state medical examiner office. So overall in the US, there are more than 3,000 counties. And when you add it all up, there's a staggering 2,000 plus separate medical legal death investigation offices, each with their own systems and bylaws. And we'll circle back to how this is addressed later, but first let's do a little history lesson, which will explain some of what you see in the slide. So how did death investigation begin in this country? Well, colonists came over to what is now the US in the 1600s, and they brought with them and later adapted various governing and legal systems. And this included the office of the coroner, which translates into of the crown. In the 1700s, the concept of legal medicine took hold in Europe, and colonies carried on with the coroner systems. Coroners were charged with investigating deaths on behalf of whoever was the sovereign or the crown. The position naturally evolved over time, and in colonial America, these elected officials were in charge of death investigation, but also had a role in curbing corruption among sheriffs who were involved in a death. Physicians at this time had only a secondary role, as they were asked to perform autopsies only at the coroner's request. So even though the office of the coroner had an original charge to curtail political corruption, over time, in many jurisdictions, the office became complicit. And in the 1800s, there was a growing effort in response to this political corruption to replace coroners with physicians. 1860 marked the first law that stated a coroner had to require participation of a physician in the death investigation process. And from that point on into the mid-1900s, several jurisdictions began to replace coroners with physicians, and some designated that these physicians, who they now called medical examiners, were to be involved in investigating only violent deaths. In 1954, additional legislation, the Model Postmortem Examinations Act, was passed but never fully implemented. It had aimed to establish a foundation to develop centralized state medical examiner systems, but the end result was that this law led to changing about half of the US states' jurisdictions from coroner to medical examiner. So this is why, to this day, the US medical legal death investigation system is that patchwork of centralized and decentralized systems at the state level, with no federal body providing oversight of these disparate systems. Some where the state have a medical examiner who has the final say. Other states delegate this authority to the coroner, or even sometimes another medical examiner at the county level. So primarily during the second half of the 20th century, numerous organizations were created to represent different groups involved with medical legal death investigation, such as the medical examiners and coroners themselves, but also the death scene investigators, laboratory directors, and funeral home directors. And each of these organizations attempted to further the standardization of the current patchwork of systems. Of the notable organizations that rose in the 1900s, one was the International Association of Coroners and Medical Examiners, or IACME. At the national level, shown larger here so you can see it, were the American Board of Medical Legal Death Investigators, the National Association of Medical Examiners, or what we'll refer to as NAME, the American Academy of Forensic Sciences, the American Society of Crime Lab Directors, the National Association of Funeral Directors, and the National Institutes of Standards and Technology. So as far as federal agency goes, the Department of Justice had been involved, and the Centers of Disease Control were involved as well. And just a minute. Sorry, I'm having a little bit of a technical issue. Just bear with me a second. Okay, all right, we're back in business. All right, so CDC had worked with the DOJ to form the Federal Medical Legal Death Investigation Interagency Working Group. And while multiple centers in the CDC had an interest in mortality data, the National Center for Health Statistics is likely the most involved since it collects the data on vital statistics like birth and death data. And the CDC and DOJ are certainly not the only federal partners that are involved in death data. In truth, many different federal agencies use or produce death data, and here are a few of them. At the state level, associations for the coroner and medical examiners also developed. And just to fill in this chart down to the county level, you can see that the coroner and medical examiner offices could be at the county level, but state level offices were led by medical examiners. Back to the timeline. So finally, in the 2000s, there was a focus on accreditation. So NAME and the IACME both developed standards for accreditation for the medical examiner and coroner's offices. And here again, you can see that these themes of collaboration, of training, and regulation and governance come up. When we look at mortality data flow, you'll get a better idea of how different agencies and organizations are involved. First of all, as we mentioned before, for non-medical legal deaths, death certificates were signed by physicians who are usually not trained in forensic pathology. Even though this icon is just labeled as physicians, nurse practitioners and physician assistants can also sign these death certificates in certain jurisdictions. These deaths are natural, and they could have occurred in a hospital setting or under the care of a primary care physician who was familiar with the decedent's medical conditions. The healthcare provider would go into the electronic health record and obtain the medical history that would then be used to complete the cause of death section of the death certificate, here highlighted in the red in the middle of the certificate. The cause of death section includes the causal sequence leading to death, contributing conditions, manner of death, circumstances from injury, among many other things. The funeral home directors enter demographic information as mentioned before in the sections of the death certificates highlighted in blue on either end of this form. So depending on the laws of a particular jurisdiction, certain deaths are required to be reported to the medical examiner or coroner. They can include sudden deaths of those who were apparently in good health, unexpected deaths of children, and those admitted to the hospital dying within 24 hours of admission, for example. Those deaths where the medical examiner or coroner accepts jurisdiction may include cases that may need only an external examination, or they could need a complete autopsy or a limited dissection. The medical examiner or the coroner will review the information collected by the death scene investigators seen here, as well as lab results like toxicology, which may be relevant to the cause of death or the manner of death. Of course, we've yet to go over the data flow chart in its entirety, but let's pause here for a moment to take a deeper dive into these different groups of people who enter data into the death certificate. So we have the non-medical legal physicians, the medical examiners, coroners, and the funeral home directors. And additionally, you have the death scene investigators who contribute significantly to the death certificate. All of them need specific training to know how to complete a death certificate. However, this training has been subpar in the past for all these groups. Clinicians, for example, who are not pathologists may only get a few hours of training on how to complete a death certificate in medical school or residency. Coroners are required to, in some jurisdictions, to have at least 1 week of training per year, more in others. Medical examiners have 3 years of pathology residency followed by a year of forensic pathology fellowship. Funeral home directors typically have a year of internship depending on state requirements, but only a small part of that is training on completing death certificate. And death investigators, as we said, go over the death certificates in their training, but in the past, their importance in finding information for the circumstance of death and the implications in public health may have not been stressed enough. So all in all, everyone at CDC has some training on death certificates, and there is still more training that is needed. So to answer this call, several different organizations have created training modules, books, guides, etc. For funeral home directors, they can access a handbook on death registration of fetal deaths. However, some of this guidance can also be applied to other types of deaths as well. In the demographics section, funeral home directors need to fill out information on occupation, and NIOSH has put together guidelines and training videos that can help them complete this part. Physicians, nurse practitioners, physician assistants, and coroners can visit CDC's website to access different training materials like handbooks on medical certification and registration of death, instructions for completing the cause of death section in the death certificate, review of common problems in certification, an online training course, and even a cause of death mobile app, which you can download to your phone. Materials that are specifically tailored for death scene investigators include death investigation toolkits for natural disasters, sudden unexpected infant deaths, sudden death in the young, and drug toxicity deaths. Over the years, the role of the death scene investigator has become more in the spotlight in regards to data quality. Although death scene investigators don't typically enter data directly into the death certificate, the information they find, particularly on the circumstances of death, as we mentioned before, can have a significant impact on how the medical examiner or coroner will determine the cause of death or the manner of death. For example, in disaster-related deaths, such as a hurricane, it's important for the death certificate to mention the hurricane and the circumstances of death section. There are checkboxes for certain things in the death certificate, like tobacco use and pregnancy, but there is no checkbox for disaster or hurricane. So instead, researchers can identify hurricane-related deaths by performing a keyword search in the literal text of the death certificate. Now getting back to the mortality data flow chart. All the information in the death certificate is entered into the electronic death registration system, which typically sits at the state level and is overseen by a vital registrar. The vital records offices are often in state public health departments, but where it sits can vary. The state registrars will send this information onto the national level to the National Vital Statistics System, or NVSS, which sits in CDC's National Center for Health Statistics, or NCHS. The states will provide this data to NCHS through the Vital Statistics Cooperative Agreement, and that includes information on the disposition, the cause of death, using ICD-10 codes. And from here, NCHS will aggregate data from death certificates across the country through NVSS, and then put together national analyses and reports like data briefs or the National Vital Statistics reports, including rapid release reports. The data can be accessed in the National Death Index, which is a database of all deaths in the US, where medical and public health researchers can go to determine the cause of death and vital status of study participants. Other databases that are available that have mortality data include WSCARS and Wonder, which we'll talk about later. So the data from NCHS also goes back to the state and local level, where they can become part of other databases. Medical examiner and coroner case management systems can also send these data to these entities. They include state and local level electronic health record databases, law enforcement databases, and other specialty databases like those for violent deaths or child deaths. From there, they become part of the National Violent Death Reporting System or the National Fatality Review Case Reporting System. You'll see that I've added a challenge theme, if you will, for interoperability data systems to this data flow slide. But of course, all challenges are hidden somewhere in this complex flow. I'd also like to draw your attention back to the challenges slide, to the overarching goals for data to be accurate and timely. Now, it can take quite a while for information to get from the death certificates to the databases to the reports where you can use them as public health professionals. So to address this issue of needing more timely data, NCHS started to release reports of both quarterly provisional and final annual death data. The provisional data is based on a snapshot of the vital statistics data received and processed by NCHS as of a specific cutoff date. And the final annual data is released after NCHS has received updates from all the states and has reviewed the data for completeness and quality. Quarterly provisional estimates include estimates of death for even selected causes of death, like drug overdose deaths or pneumonia, influenza, and COVID-19. Now, going back to these challenge themes, let's address the issue of no official national oversight in more detail. So some organizations have put together accreditation standards. As we alluded to before, IACME and NAME are a few. As part of NAME's accreditation process for medical examiner and coroner offices, a checklist needs to be completed. And this includes a lot of different sections, some of which are mass disaster plan, investigative practices, annual statistical report, evidence and specimen collection, histology and toxicology practices, professional credentials, training and education, and performance evaluation. IACME also offers accreditation and has similar sections covering things like reports, safety, QA, personnel, body storage, autopsy procedures, and labs. However, as of 2018, only 17% of the medical examiner and coroner offices were accredited. So there's a long way to go still. Now, accreditation is applicable to medical legal death investigation offices, and they ensure that the offices are operating competently with necessary facilities and equipment. But personnel also need to be certified to ensure that they're qualified and have obtained the requisite knowledge, skills, and abilities to perform their jobs. Some accreditation of offices require that personnel be trained and certified in their respective fields. Medical examiners are physicians, and they will have pathology board certification. Death scene investigators can be certified by the American Board of Medical Legal Death Investigators. But regardless, many different individuals who have a role in medical legal death investigation can be certified by a large number of different groups, as seen in the list here. So, as we just mentioned, recent demands focus on timeliness and accuracy of death data. In very simplistic terms, any surveillance system has those who collect and enter the data, those who clean the data and generate the statistical reports, and those who use the data for action. Sometimes these are all the same group, but oftentimes they're not. So there needs to be adequate collaboration between these various stakeholders. And just as people need to talk to each other, it's greatly beneficial to public health surveillance when data systems can talk to each other or are interoperable with each other. These are the two main challenges that have been addressed by various organizations and agencies, especially over the past several years. I'm going to go over some of these initiatives. For a little bit of background, in 1986, CDC established the Medical Examiner and Coroner Information Sharing Program with the goals of improving quality of death investigation. Although this program couldn't continue due to funding and other logistical issues, it shows that the concept of promoting collaboration among disparate jurisdictions is not new. So in 2022, CDC established the Collaborating Office of Medical Examiners and Coroners, or COMEC. And COMEC provides broad support for public health activities to professionals who conduct medical legal death investigations. And we actually have Margie Warner, who is the director of COMEC at NCHS, online with us. So if needed, she can chime in during the Q&A session. So other stakeholders that are involved include those at the state, district, county level, the medical examiners, coroners, professional associations, different public health and federal agencies. And the goal, again, was to foster coordination among public health surveillance efforts and the medical legal death investigation community to promote quality and consistency in the process, promote collection, automation, and distribution of data, analyze and compile information about infrastructure, and arguably the most important, facilitate information sharing. So COMEC has established a forum for this collaboration and dialogue for the bridging of silos by holding a monthly virtual seminar series and weekly office hours to help with technical questions. So if you go to this website, you can see how they brought together resources from across CDC and other agencies and house them in this all-in-one, easy-to-access location. Here you can find information, including many of the training materials we just covered on death certification, including handbooks on how to certify and register deaths, commonly encounter problems with death certification, online training, and the Cause of Death mobile app. There's a link to NVSS, which also provides training and instructional materials, and There are links to other data systems within CDC that focus on different topic areas like sudden unexpected infant death and sudden death in the young surveillance system, the National Violent Death Reporting System, information on disaster mortality surveillance, and the State Unintentional Drug Overdose Reporting System for comprehensive information on drug overdose deaths. COMEC even has links on how to handle specimens from autopsies suspected of having infectious disease, cause of death like COVID, monkeypox, or Ebola. In addition, CDC's health law program assessed coroner and medical examiner laws across the US and amassed a comprehensive list of all these organizations within each state, whether those organizations were at the state or territory or county level. So this includes in links to coroners associations for particular states. And there's also a link on COMEC for death scene investigators where they can find training and death scene investigation forms for different types of deaths. Finally, COMEC highlights mortality data modernization efforts that refer to creating interoperable, accurate, and real-time data systems talking to each other in a timely manner to get actionable data. The vital statistics offices have a long history with data modernization to bring about electronic death registration system, but more recently, the NVSS Community of Practice and the MDI data modernization groups have been working on getting the medical examiner and coroner offices data systems up to speed. The tools for this modernization include interoperability, which refers to the ability of different information systems, devices, and applications to access, exchange, and integrate and cooperatively use data in a coordinated manner. The MDI electronic case management systems have been implemented in many jurisdictions. This is usually a commercial product purchased from a vendor, but it can be an individual office's standard software system. These case management systems allow for standardized data entry, queries and data searching, report generation, and easy dissemination of case materials. Interoperability of these systems depend on the application programming interface, which allows services and products to communicate with each other. A common application programming interface, or API, is the HL7 FHIR, which stands for Health Level 7 Fast Healthcare Interoperability Resources. And this allows communication of information using a common framework and breaking down complex data into digestible, usable pieces. Guidance has been developed to help MDI offices use the FHIR resources to exchange data with others. Data modernization also involves providing these MDI offices with technical support and establishing MDI Connects and implementers collaboration that's in partnership with the CDC Foundation. So this national learning collaborative will enable the MDI offices to pilot the use of FHIR to improve MDI data exchange with data sharing partners. The MDI testing framework called RAVEN allows the medical examiner and coroner offices to test tools for interoperability using FHIR between the case management systems and other external systems like the electronic death registration system and the vital registrar at the state level, or forensic toxicology lab information management systems, or LIMS. Additionally, there's a community of practice for NVSS modernization of vital record systems that promotes the sharing of ideas, technical tools, resources, and best practices. So this is just an overview of some of the advances made in death data over the past several years. I wish I could go over more, as there are so many products and reports from so many different groups. Here's a very, very long list of links to additional products that aren't in any particular order, and you can use it to learn more about specific mortality data projects and products. But just by looking over the names of these links, you can see that there's a breadth of centers, groups, and stakeholders that are involved. So let's take a breath. We've gone over a lot, but what are the big takeaways? Well, not unlike challenges elsewhere in public health, we need more standardization, more training, more funding, more people, more interoperability, and more collaboration. Basically, these needs cover the national level data system, NVSS, and all the upstream parts that go into it. And all this is really important to you as public health professionals or researchers looking at these databases, analyses, and reports that are downstream. You can access death data through CDC Wonder, which stands for Wide-Ranging Online Data for epidemiological research. This is an easy-to-use menu-driven system that makes the information resources of CDC available to public health professionals and the public at large, and it includes mortality data. You can also access WSCARS, which stands for Web-Based Injury Statistics Query Reporting System. This is an interactive online database that provides fatal and non-fatal injury, violent death, and the cost of injury data. And there's also the National Death Index that has information on all deaths in the US. But there are several more databases that provide information that you can access as well, such as the National Occupational Mortality Surveillance, among others. The point is, there are a lot of ways you can get death data for your projects, but next time you do so, just with any data you obtain, think about the process involved in collecting and reporting that data. Think about data quality, its timeliness, its accuracy. What is the gold standard? In many mortality surveillance reports from NBSS, that is what the gold standard is, those data that are coming out of NBSS. But there are so many different organizations that we haven't even covered here that are tracking mortality data, and the numbers can vary by quite a lot. During EIS, I reviewed death counts from different agencies for disaster events. In one hurricane, one place counted 4 deaths and another 104 for the same hurricane. You have to ask yourself why these discrepancies exist and think back to the process of collecting and reporting death data. Your project might be to evaluate and compare different methods of death data acquisition. For example, in EIS, I worked with a state vital records office to evaluate using a flag in the electronic death registration system to identify deaths related to a series of tornadoes. When we compare this to searching for the term tornado or twister in the how injury occurred section of the death certificate, and then also to our gold standard of looking for the tornado ICD-10 code in the data sets that the state received back from federal agencies, what we found was pretty surprising. The flag was the most sensitive and timely marker. And yet another project, we compared state vital statistic records of hurricane-related deaths to law enforcement records of the deaths, and compared those also to deaths that we tracked in the media. Here we found that while there was some overlap, the best way to find all the related deaths was to look into all the different systems. So going forward, you might be involved in evaluating these programs and systems put into place to modernize death data. And here, if you're a preventive medicine fellow or resident, you can apply the skills you learned in program evaluation, project management, or policy analysis. Maybe you'll even come up with a logic model like the one I put here for mortality data. There are just so many ways where you might become involved in mortality data. Well, I've taken you on most of this roadmap. Now, as a public health professional, you hopefully learned a bit more about death data from this talk, and at least where to go to get even more in-depth information. You know where death data flows, how the medical legal death investigation system came to be, and why it's so important to public health. What challenges it's faced, what initiatives have been taken to address those challenges. So finally, I leave you with the question mark. What are the next steps? What more can be done to improve death data quality, timeliness, usability in regular day-to-day public health practice, as well as when public health emergencies rise? Well, in summary, keep doing what you're doing because it's working. Keep expanding these initiatives for modernization to more jurisdictions, keep sharing experiences with communities of practice. At some point, if it's not already started, we'll need to evaluate the progress of these different initiatives. And finally, for that ever-present issue of funding, look to leveraging different health threats to secure funding for the projects past the pilot stage. So today is the first time in several years I've had the opportunity to present on mortality data, and I am in awe of how much progress has been made, particularly in the areas of interoperability, collaboration, and training. And even though I wasn't directly involved in all of them, I really do have a profound and personal appreciation for it. I completed my forensic pathology fellowship back in 2011 at the Fulton County Medical Examiner's Office. Back then, we were still using paper-based systems to complete death certificates, and we were just in the early stages of using an in-house electronic case management system. And look at it now. I can't wait to see what happens in the next few years. Till next time, thank you again for your time today. And thank you to all of those who helped with this presentation and caught me up to speed on the advances over the past few years. And of course, thank you to all my mentors and my training at Emory and CDC.
Thank you. So this presentation is now open for questions. If you have a question, you can put it in the Q&A box on the Zoom link. So Nanda, we have the first question is to talk a little bit about in public health, what types of jobs are available for forensic pathologists, and then where do they often work? Like what types of sections of public health are they? And then who uses the data in public health for the medical examiners and pathologists?
Yeah, so as far as where forensic pathologists might go, I think my journey and my professional journey might be a little bit of an example that you could use, because I came out of a forensic pathology training program, and then I decided to take a different direction and go into public health. That being said, you can certainly, become a forensic pathologist, get boarded in pathology, get boarded in forensic pathology, and then explore what else there is in public health. There are options at the state level. I would recommend different fellowships here at CDC. We have EIS, which I mentioned many times in this talk, and the Preventive Medicine Fellowship was also a great option, but there are many other fellowships as well, especially for those who have MD training. And as for, sorry, could you tell me the second part?
Yeah, where do you where in public health, I mean, maybe like the Injury Center and National Centers for Vital Statistics, and where are the data being used in public health, and what kind of sections in the health department do use them?
Yeah, so the parallels at like the state level or local level health departments are the same as what you see at the federal level. So like you just said, the Injury Center at CDC works a lot with the death data and suitors, which I mentioned in the talk. Those who are at NCEH work on disaster-related data, death data, and everywhere, really, even in chronic disease, there is an avenue to use death data, because all of these health threats, the ultimate and worst case scenario is death. So that is a measure of chronic diseases, it's a measure of disaster events, and the list goes on. So you really can apply it anywhere.
So the next, oh, sorry, I see.
Yeah, so yeah, I just wanted to add, was asked to be a discussant. I wanted to make sure to be clear that one of the big areas that it uses in information for medical legal death investigation currently is for drug overdose deaths. That's really a high top profile area, and the medical examiners are the first to encounter the new health threats, and they are able to track the information, and they provide information, as Nanda said, both to us at the National Center for the Suitors Project, but also within the states. And then also sudden infant death is an area that plays a big role with the medical examiner and coroners. So trying to understand sudden unexpected infant deaths where they don't know why the infant died. We get a lot of information from medical examiner offices, and also sudden death in the young, where for instance, with teenagers, and Nanda can speak a little bit more to the medical part of that. But I would also mention that infectious diseases, we have a big program with infectious diseases. Nanda mentioned it, where we are able to look at specimens from offices to help make sure that there aren't any new and emerging threats.
Yeah, those are really good points. And it just reminded me, I briefly worked with the people at GBI, the Georgia Bureau of Investigation, on the Sudden Death of the Young project. And it was really phenomenal. And this was so many years ago, but even then you had all different counties coming together, medical examiners from local areas coming together to discuss different cases. So that element of collaboration has been there, and I think it's growing, and it's great.
Yeah, there's review teams for different causes of death within states, fatality review committees. I think that's what you were involved in, the infant fatality reviews and child fatality reviews. And now there are reviews now for drug overdose deaths in some states. I also, another area that I wanted to make sure to highlight was suicides and other violent deaths, homicides as well. So the National Violent Death Reporting System gets information from medical examiner and coroners. That's a system we run at the injury center, or CDC runs through the injury center, and is collaborative with the medical examiner and coroners.
And I'm glad you bring that up, because a question just came in about NVDRS. So if you would be able to speak to how can we better capture suicide data, and they mentioned that NDVRS is used for that, and that coroners often rely on next of kin to understand cause of death, and there's a stigma of suicide. It may not be accurately captured. What do you think can be helped with that to better capture suicide data?
Well, I don't have particular expertise in this area, but I would guess that it has something to do with looking at many different systems that are tracking these types of deaths, not only what you traditionally think of or what might be the gold standard at the federal level, but I guess something like, I know in recent years, the 988 number for suicide prevention, they've been able to actually track people who may be, at risk for committing suicide and track them down. And so I just think that that may be an option of a stakeholder that you might want to engage, but there are many more, I'm certain.
Now, did you want me to, I just wanted to highlight a little bit too, the related to suicide information. Much of the information does come from the offices of medical examiner and coroners, because they're the ones that are investigating these deaths. And many of them do not happen in a healthcare setting. So, and the person is already deceased. So the medical examiner when they're investigating, they learn the most about the deaths, as well as potentially the law enforcement when they're involved in the scenes. But the medical examiner and coroners follow this when they go to the scenes and do the scenes in a consistent way. They gather a lot of information that can be used for public health. How they report that information in their systems and how that information can be gleaned from within their case management system is some of the work that we're doing with the data modernization activities. But also, Nanda talked a lot about the training. There's more and more trainings for the investigators, including the certification of the investigators to get that basic information that's then given to the forensic pathologist who is doing the autopsy.
Exactly. Thank you. No, there's definitely a lot of, I guess, granularity might be the word, that we're looking for more detailed information on these deaths, and that can be captured in the death certificate, and all these different people have a role in that, but death scene investigators are very crucial to that.
So our next question's about time from autopsy. So from time of death to the actual autopsy exam can be done. The person who asked this question has experience with animal research, where you often euthanize the animal and they can fix and store tissues immediately, which can hopefully help with assessing a lot of different diseases, conditions that affected the death of the animal. Is there limits with human autopsy of how long you have to wait? Is there any consideration when you're looking at the data systems for screening out autopsy data to rule out records that can't catch certain conditions because of that?
I'm not really aware of any systems that might exclude that type of data. I do know that during the autopsy or right before the autopsies, there are certain procedures and they vary, I'm sure, from jurisdiction to jurisdiction to office, to a different office. But there have to be certain procedures that go on before you can start the autopsy itself. And then once it starts, you can collect tissue samples, you can send off blood, urine for toxicology, and those tissue samples are collected for some period of time and kept, but they can also be made into slides, and those slides we can look at under the microscope as well. So I'm not sure if that answered the question quite, but Margie, feel free to chime in.
Yeah, I would also just highlight that some of the accreditation of offices that Nanda mentioned, they actually create the time frame from within which the autopsy has to be done. There's a part where they're discovering the body. Unlike the case that the questioner, there are cases where there's been a time already elapsed before the medical examiner and coroner offices notified of the death, and so sometimes by definition they have to do the autopsy with less than adequate conditions. But I would also note that something kind of interesting is the retention policies, and Nanda can maybe speak to this, but for certain causes of death, there are retention policies on keeping, especially for those unexplained deaths and with infants, they try to keep certain specimens so that they can go back and look through for certain, they learn about new infectious diseases that may have contributed, then they can go back and with the permission of the family to learn more about what may have caused the death.
Yeah, and sometimes they even there might be a second opinion that's needed. They might have to do a second autopsy. So it's good to have those tissues for a certain amount of time.
So there's a question about with all these different data systems, do you think in your opinions that it's more beneficial to integrate all of the different data systems, or should more effort instead be put into linking all of the systems to provide accurate counts of data? What's the best step in your opinion for the next?
Yeah, I would guess this would be a great one for Margie to answer, because this is her wheelhouse. But I think the HL7 FHIR, that sort of API is where they can talk to each other. So I'll let you expand more on that.
Yeah, I mean, I'm not sure what the difference, the question. Let's start with the fundamental part here, which is that the medical legal death investigation systems and the vital registration systems are both state-based activities. Those are the state has control. There's statutes and regulations for both vital registration and medical legal death investigation within states. So creating interoperable systems really starts with how the state wants to function. But interoperability between systems is super important, and that's quite different than linking a system. So interoperability is about sending information back and forth between the systems. And I'm not sure where the question was, how the question was phrased, but I guess from our perspective, we're starting with standards-based interoperability, trying to make standard items that need to be collected on each death so that no matter where you are, you know what items need to be collected, and that is and retained, more retained in the case management systems if they're electronic, and then working on getting systems to talk to each other. But none of that is really, we're really in the infancy of starting that. And it's so creating a full-fledged system throughout the country is really in its infancy. I would add that there are many of the smaller, more rural offices that don't have an electronic system at all, so they're totally paper-based. So more to come on sort of how to get all those systems electronic, since it is a state-based system, and that's
no, I remember during my training that there were some jurisdictions where they were entering information into the medical examiner case systems and then re-entering it into the vital statistics or the vital registrar at the state level into their EDRS. And you can just imagine in having to do both, there were some data quality issues, incorrectly entered items. And so when you have them both being able to talk to each other, it kind of skips over that possibility of having those errors. And I think, at least from what I've heard in COMEC, like a lot of offices are really happy about that.
Yeah. So that's a great way for me to advertise or not advertise, but make sure to clear up that you mentioned the and National Vital Statistics Community of Practice, which is the community of practice of the vital registrars, as well as the Medical Legal Death Investigation connects. Both those projects initiatives have ways to for the medical examiner and coroner to electronically exchange information with the vital registrar, and we have lots of examples now of different sites that have done that, including the whole state of Connecticut. Georgia has a few instances where they're exchanging information electronically, and I'm trying to remember off the top of my head the other ones. Minnesota has a couple of examples. So that is coming, and that you're absolutely correct. Currently, many of them print out the death certificates and then a clerk types it into the electronic death registration system. And we're trying to that's a first step towards creating interoperability between the systems.
Great. Next question is there a national standardized method to record a full-term stillbirth? Do states conduct their own record keeping of that?
That is a great question that I simply don't have the answer to. I don't know if there's anybody online. Or Margie, go ahead.
I can answer it a little bit, but there are certainly people looking into this, and many of them have joined, talked a little bit with the medical examiner and coroners. There are certain states where medical examiner and coroners investigate this still. I'm not sure exactly how the question, the fetal deaths. But this is something we have the fetal death registration, but I'm not sure whether it's national. There's been a lot of work in this area, or a lot of exploration and looking at the landscape, so we can refer the questioner to the right people, but it is something that is being explored for sure.
Great. Just a reminder to everyone that if you have any questions, you can put them in the Q&A box. We have no open questions at the time right now, but feel free to ask questions while we have both of you here. Nanda, hearing especially about the differences in training and such for medical examiners and coroners, are the jurisdictions that have medical examiners versus coroners different? Like, are there more likely to have be close to a medical school, or are they more likely to be rural versus urban, or larger jurisdictions versus smaller? I don't know if you can speak to some of that, if anything is known between those two differences.
That's a really interesting point to bring up. I hadn't really thought about it in terms of like where the medical schools are located, but the states that have all coroner counties, they might be rural, they might be more urban, but Georgia's a really neat example. First of all, because it has so many counties. And what you'll find is that it almost has a little bit of all of the different systems, where the corner systems are more rural, and there's just a handful of medical examiner counties just around Atlanta. And then they also have the GBI, which is the Georgia Bureau of Investigation, and they do the autopsies for a large number of the counties in the rural areas that are not, directly around Atlanta.
Yeah, I would add that Georgia, the way Nanda described Georgia, is similar to many of the states that have a mixed system with both medical examiner and coroner, and the coroners do tend to be in rural. Not all, some states are entirely coroner based. And so no matter what the size of the population is, they still have a coroner. Some of those coroners tend to be elected, and oftentimes in larger jurisdictions, the elected coroner may in fact be a forensic pathologist or a medical examiner. For instance, that's what's happened in Ohio with the larger jurisdictions. But medical examiners tend to be in the Northeast, statewide medical examiner systems. And there are also, you mentioned the university, which is interesting. There are a lot of, not a lot, but a fair number of the larger offices are associated with the institution like a hospital or a large medical school. And that's important for public health to understand, because those offices are allowed to do research, quote unquote research. And they have more opportunity to do research. Some of the offices are really restricted in, there are all obviously protocols for IRB and consent and all that kind of stuff, but some of them are strictly restricted from doing anything, any kind of research, because they're because of where they're located within the county government. So.
Great. Well, we have no further questions that came in from the audience, but I wanted to thank both of you. Thanks for the presentation, and thanks for taking the time to answer the questions that we've had. It's a great topic, very exciting to hear about the work that's being done. And I want all of our attendees to be aware that our next Preventive Medicine Grand Rounds will be in December. So look for the announcements about that presentation. So thank you everyone for your time today, and we'll see you in December.
Great, thanks so much.
Thank you.